Once again, you thought you were going to see President Putin. I'm going to disappoint you once again. President Putin is not coming here. We left him behind at the Sochi Olympics. But you are watching Boritzer's Bio Briefings, where we talk about everything but politics. We're talking about biology, we're talking about proteins, we're talking about biotech, we're talking about healthcare, we're talking about medical records, on and on and on. Whatever we think you'll find interesting, entertaining, and enlightening. We have a special guest today. Our guest is Professor Clair Wright. Professor Wright holds two positions. She is a professor of obstetrics and gynecology over at Kapiolani Division of the Japson Medical School. Is that correct? Okay, I don't want to get the titles wrong. And also is a professor at Chaminade University in the Biology and Science Department. Mm-hmm. Very good. Welcome aboard. Thank you so much. Aloha.
Thank you very much for inviting me today.
So if you need a translation, because we have actually an English speaker who speaks correctly, what you've been watching in the past is really a pseudo-English. Today we should have the Queen's English or the King's English in the past, and we're going to hear English talked properly, pronounced properly. Professor Wright is an expert in preterm ending of pregnancy and the dangers of pregnancy, aside from just the joys that we usually anticipate. Over here, my name is Dr. Rafi Boritzer. I'm your weekly host on the Boritzer Bio Briefings, and we're happy you've joined us. Welcome, Professor Wright.
Thank you.
And we'll start off a little bit. I want to create an aura of the seriousness of the topic we're going to discuss. Aside, we've talked in the past about fertilization, we've talked about in vitro, we've talked about the processes of attempting to achieve pregnancy. Today we're going to be talking about the dangers and the pitfalls that carrying a fetus to term. And Professor Wright is, aside from the fact that she is a researcher in the field and going to illuminate for us a bit of the research on it, is also an expert in medical education, had some experience in that as well. And what other subjects would you like to discuss today?
I'm very happy to talk today about preterm birth. That's really where my research interests lie. So as you say, I'm really interested in what happens at the end of pregnancy. We've heard before that you've interviewed people about the beginning of pregnancy, so it will be great for us to talk today about the end of pregnancy, and how that often ends too early, and so the pregnancy ends too early. And then what the consequences really are for the moms and for the babies, because they're things that really impact everybody. They impact the whole family that's having the baby and the health of the baby in the future. And so let's talk about that today and what we know about that and what we really need to do to help to address some of the problems to help improve some of the numbers of these babies that are being born too early in the islands.
So perhaps for the non-physician or non-biologic professionals, we left off with our previous guest as the sperm was making a valiant swim against the current, trying to fertilize an egg, and then the watchful time, observing, watching, again observing, monitoring, as making sure that the egg gets fertilized. And that was the big event. And once the egg gets fertilized, could you kind of take us from that point?
Okay, so once the egg is fertilized, then the egg is going to, to burrow into the uterus, into the uterine wall, so become really one with the mother, and then to grow all of the tissues that are needed. So the mom and the baby interact with each other very closely, and they kind of have this conversation with each other during the beginning of development, so that then the placenta that we have that helps to provide the nutrition for the baby gets set up, and then also the fetal membrane, so they're the tissue that surround the baby that become one with the mom's uterus throughout the pregnancy, start to develop. And then really people, as long as the pregnancy is going well, tend to sort of lose interest in the middle of the pregnancy. It's a little bit uneventful. The baby is growing, it's developing, all of its organs are developing and getting bigger, and we're monitoring the baby. But really, at the end of the pregnancy, that's when things start to get interesting again. So as long as the pregnancy is healthy and relatively uneventful, then we're sort of waiting for the end of pregnancy to see, is the baby going to develop to the full term, and everything's going to be all right with the delivery. That's the thing that moms become most anxious about, is what's going to happen when they actually have to give birth. And so when we think about pregnancy, we think about it being a full-term pregnancy as being 40 to 42 weeks. And so when we speak about the pregnancy being preterm, what we mean by that is that the pregnancy or the baby is delivered, the pregnancy ends before 37 weeks.
Take us back for a second, going backwards in slow motion, looking back at the soundtrack. That point where the egg attaches itself to the wall and the tissue starts building, is there any dangers at that point?
There are lots of dangers at that point in terms of the survival of the growing baby. Is the baby developing properly? And so there are lots of developmental checks that come in place that mean that, you know, many pregnancies are lost in the early stages of pregnancy. And so then we tend to think that once the pregnancy has reached 12 weeks, it's very stable and it's unlikely that you will lose the pregnancy at that point. And so then you come into this very kind of quiet, nice growing environment for the mom and the baby until the end.
I see.
And then things change again.
Now, are there any, in terms of the danger of the loss of the fetus, are there any early warning signs?
So you mean in the middle of pregnancy?
Yes, in the middle of the pregnancy.
When we're monitoring, or when physicians are monitoring the pregnancy, they are you know, making sure that all the right growth characteristics happen. So when the mom and the baby, they're going for their scans, they're measuring that all the organs are developing properly, they're measuring the size of the organs, and making sure that everything is developing, the baby is developing the right size. So often moms hear that physicians say, okay, what percentile is your baby? So meaning, is the baby small for its age, large for its age? And that can give us clues to whether the baby, whether there's any problems with the pregnancy. So if a baby is small, it could be for a number of reasons. One of those reasons is maybe there are problems with the placenta and the baby's not getting enough nutrients and oxygen. Obviously, the mom looking after herself is very, very important. So to make sure that the mom is getting enough nutrition and enough activity to keep herself happy and healthy as well, that contributes to the baby's health and well-being.
I see. Now, a lot has been stressed, especially in popular literature, that, as you say, the mother's behavior has some input or some effect on the pregnancy. Are Americans or people in general too worried about the behavior of the mother at this point?
I think it's really clear that the behavior of the mother is very, very important. I think the danger that happens is that people read one report and act too quickly on that report, perhaps, and that they take things to extremes. It's really clear that what the mom needs is a very balanced, varied diet, and that, you know, too much of anything is a bad thing, whether it's, you know, and so what's important is that the mom gets as many different types of fruits and vegetables and different types of foods from all the food groups that she can throughout the pregnancy. And that, you know, thinking that eating one thing is going to be a master cure is a mistake. You know, it's variety and keeping yourself healthy and active is what's important.
See, I mean, the once a day vitamin that people like to, they think that everything they look on the bottle of the pill box, whether it's at Walmart or Costco, and they say, okay, so it has the potassium, it has folic acid, it has this. That's all I need. I take one pill and I can go to the bar and hang out with my friends and have a couple of martinis.
Yeah, it doesn't quite work like that. It's good to cover yourself with a multivitamin, absolutely, yes. But it's much better to get all of the other phytonutrients and things that you need from your normal diet as much as possible. So that's the freshest, that's the best way to
stick with
that.
The veggies,
absolutely.
Watch the carbs,
yes.
Watch the fats.
Yeah.
And let's move on. Okay, so now we're going. It's kind of smooth. You said till about the which week would you say we were
well,
safe?
when we start to think about preterm birth, what you see really clearly is that babies that are born between sort of 22, 23 weeks, they're really not able to survive outside the mom. You know, they're too underdeveloped. And so what we really see is that that's when we start to think about preterm birth. And we see that those babies that are born very early, around 22, 23 weeks, they're the ones that end up always, you know, in the intensive care unit. And the rates of those babies that don't make it are very, very high. And that as you move towards that, you know, that 37 weeks that we still consider as preterm, then the consequences become less and less severe. You know, we have more of those babies surviving, more of those babies going into the neonatology intensive care unit and surviving on ventilators and, you know, you kind of, if you like, living out the rest of their time when they would have been in the womb actually in the intensive care unit. And we're able to, you know, do pretty well now with those babies in the intensive care unit with the medications and care that they get. But one thing that is usually a surprise to people is that even those babies that are born later preterm, so the ones that are more sort of 34 weeks up to the 37 weeks, even though they might not end up in the intensive care unit, there are still consequences for those babies. They often still have some respiratory distress because that's one of the last organs to develop. And also, you know, if you're born preterm like that, you have increased risks in your adulthood for cardiovascular disease and metabolic disease and type 2 diabetes. So, you know, this kind of consequences are a huge thing for someone who's born like that and set up programmed like that for their life.
One of the things we don't talk a lot about, because we think that medicine and machines and drugs can fix almost anything, we don't talk about the consequences of this early term births, the consequences of not being in the womb. You know, we think about it's like a myth or it's a kind of nice fairy tale from you know, storybooks in our past, but the question is early birth, even with all the support and all the dealing with potential issues like diabetes and other issues, do they suffer from not coming to full term in the womb?
Once they're out of the womb?
Yeah,
yeah, absolutely. And so it's not as so as I said, those earlier babies, it's very obvious that a lot of their organ systems aren't fully developed. So they have, you know, intestinal issues, they have problems absorbing their food, they have problems, they have neurological disorders. And so they're very kind of obvious things that we can see when we see those babies being born very early. You know, they're very obvious and medicine can help them. But one of the things that we see and that is a consequence for these later babies too is what happens with lung development. And so during the pregnancy, at the end of the pregnancy, that's when the lungs are really growing and developing, and they develop right to the end of the pregnancy. And so what happens is that when you think about lungs, you think lungs need to be as big, have as large a surface area as you can possibly have so that we can breathe as much oxygen for our tissues and for our bodies to be healthy. And so what happens with these babies is that they're still in this growing phase. And so what happens at the end of the pregnancy is that the lungs are growing as much as they can to increase the surface area, and then they differentiate. So what that means is that they change shape so that they can take on their function and so that they can absorb as much oxygen as possible. So the balance that you have is that if they develop too early, we don't have as much lung area as we would have if they were allowed to continue for longer to grow and to increase that surface area. And so that's the area that that's what you're left with for your life. So that sets up a different kind of baseline. And so that is a problem. And so these babies often have respiratory distress syndrome or chronic lung disease because their lungs are mature earlier than they should do. They don't have as much surface area as they would have done otherwise.
Well, let me play devil's advocate for a
Okay.
second. You know, we keep hearing about stem cell research. So you would think, hey, if we can regenerate tissue, you know, to measure, to fit the infant or the birth or the fetus or whatever, why not just grow a good pair of lungs?
That's an interesting idea. I mean, so what's happening is that you would, in theory, and it's fantastical for sure, you would have to, I don't know how you would even do that with babies' lungs. I mean, there is an absolute precedent for that, for growing new organs, but it's usually in response to repair or damage and those kinds of things. But to grow another lung lobe or something with stem cells, I can't even imagine.
Well, we know we do
that.
lung transplants.
Yes,
so you would think that you grow in a petri dish a little lung, just a standby lung, and you have a few petri dishes that have 1 month lungs and 2 month lungs and 8 month lungs, perhaps bigger, than maybe a little pot, maybe a soup pot or something for the bigger units. But in theory, I would think that this perhaps would be a way, although maybe we will come to a solution of the preterm pregnancies much earlier.
Yeah, that seems a simpler way to go than growing a new lung. Another thing that happens is that, you know, there are changes with the baby's lungs once they get onto a ventilator. So the baby's lungs, you know, that's a very kind of harsh environment for those tiny, delicate lungs. And so that's necessary because the baby isn't capable of breathing by themselves at that stage, and that's why they're on the ventilator. But there are, you know, there are always, we think medicine is so powerful and can fix anything, but there's always a little bit of kind of compromise that goes on with being able to use that kind of intervention, and that's why it's called an intervention.
Hold this thought. When we come back, we're going to talk about your work and your research in this particular area and how to assure full-term pregnancies. And you've been watching to this point Boritzer's Bio Briefings. We're going to be taking a break for our sponsors. You're right here on Think Tech Hawaii Television. And don't go away, we're watching you.
I'm Jay Fidel. That's Sharon Moriwaki of the Hawaii Energy Policy Forum. And every Wednesday we have Hawaii, the State of Clean Energy. We've been doing it for some time now, and we have some fantastic guests on there, unbelievable guests who give us insight into what is going on in a very complex, sometimes very confusing, sometimes very disappointing area of progress in the state. So we love doing this. We love meeting them. We love talking to them. We love having their ideas out on the table. So maybe, just maybe, we can all make some sense of what's going on. Sharon, what do you think?
I think that's absolutely correct. We enjoy ourselves meeting with all these people and hearing about the energy and the state of clean energy, and hopefully we advance clean energy for the state. So it's terrific. Join us.
Okay, it's every Wednesday. Okay, Wednesday is Energy Day. Every Wednesday, 4 to 5 p.m. Hawaii, the State of Clean Energy, here on Think Tech Hawaii. We'll see you there.
We're watching Boritzer's Bio Briefings right here on Think Tech Hawaii Television. Our special guest today's show is Professor Clair Wright. We're talking about the ending of pregnancies before they're due, and we're talking about some of the research questions that's brought up. As we left before the break, we were talking about the possibility of growing new lungs for lungs that are not fully developed. Obviously, it's part of the science fiction, perhaps an Asimov movie in the future, but perhaps you would tell us a little bit about your research and how we can deal with some of the issues and prevent early failures in pregnancies.
Yeah, so what is really clear to us right now is that there are some very pressing unanswered questions about why prematurity occurs. And so what we see is that prematurity occurs some of the time because there's been an infection that's moved to the tissues involved in the pregnancy, so it kind of moves into those tissues around the baby and sets off a reaction in the mom. And so a lot of preterm birth is actually caused by infection, or is kind of defined as being caused by infection. The more interesting ones are the ones that have no real cause. So there are lots of those ones where we really don't understand what's going on. So there are other medical conditions that we know very, very strictly cause preterm birth, you know. But there are still a huge number of those that aren't medically indicated and that aren't caused by infection, that we don't understand the cause of them. And so when we're thinking about preterm birth, we can think about what happens during delivery of a baby, and that the mom's uterus has to contract. So we have to be able to have that muscular tissue ready to, if you like, to push the baby out. That has to happen. We also have to make sure that the channel that the baby's going to move through has to be open, so the cervix has to be ready so that the baby can pass through. And also that the bag that's around the baby needs to burst. And so it's this bag that's around the baby that's of a particular interest of mine and the area that I'm working on at the moment. And so when we're thinking about this bag around the baby bursting, that's when we know the mom's water's broken, and that's a sign that everybody knows. Everyone kind of knows that with their family experience. And so that can happen too early. And so then the baby is left in the uterus, still in the mom, without the fluid, the protective fluid around it, and without that barrier, so it's kind of open to infection, and so that can cause preterm birth.
So you're in the lab, okay? You obviously can't have live fetuses to work on. No. There's some ethics issues involved. And so how do you conduct research in the prevention of premature birth?
So what we do is we work very closely, my research group works very closely with the doctors at Kapiolani Medical Center for Women and Children. And so we collaborate with the surgeons there that are doing cesarean sections. And so some women that are at Kapiolani Hospital are having a cesarean section, not because they have anything wrong with their pregnancy, but perhaps because they had a cesarean section with their previous pregnancy. And so there's an increased risk that you will need one for your next pregnancy. Your pregnancy is perfectly healthy, it's going to term. And so what we do is we can use these tissues, we can collect them at cesarean section and study the tissues. We can study what's happening with the tissues and the normal processes. So we think if we can understand properly what's happening with the normal processes and what normally happens so that this bag bursts, so that the baby then can be delivered, then we can understand how that may or may not go wrong if this happens too early. So there are some huge problems with working with this tissue because this is at the end of the pregnancy. And usually, this is a waste tissue for the body. So the body isn't invested in this tissue anymore. It's not looking after this tissue anymore because it knows that during the final stage of delivery, you expel the placenta and the membranes too, and that's the end of your delivery. And so, it's really a challenge for us to work with this tissue when it's degraded, if you like, when it's run its course. And so we can collect this tissue, we can work with this tissue, we can look at what proteins are there and some of the mechanisms, and we can also isolate individual cells from this tissue too, and then look at how they react when we treat them with different things, and to try and understand, how the pathway fits together and what leads to the normal kind of weakening of this tissue.
So you actually have to get to the cellular level.
You have to get to the cellular level. You have to. And it's difficult because these cells, I tend to think of them a little bit like a blueberry muffin. So these cells, they're in the membrane and they're kind of interspersed like your blueberries inside your blueberry muffin. And they're surrounded by all of this cake, all of this tissue that's there that isn't cellular. And it's that sponge cake around the blueberries in your muffin, if you like, that degenerates as you get towards the end of pregnancy. And so when we're trying to understand the interaction of the cells with this stuff that's around them and how together the combination weakens, it's really difficult because it's already started to crumble and come to pieces. And so what we're trying to do now is try to rebuild this tissue, if you like, try to take the cells and put it back into fresh surrounding material so that we can study the interactions of these cells with the surrounding materials. How are they communicating with each other? How is, on a cellular level, are those cells controlling the breakdown of this surrounding material that's around it that gives it the strength?
Oh, that is absolutely amazing. So you're trying to recreate in a theoretical form a placenta.
Well, the fetal membranes, not the placenta.
Oh, okay.
Yeah, the placenta is a much more complex. I mean,
Yeah.
the fetal membranes are a nice tissue in some ways to work with because it's a very layered structure. So we're starting to try and layer this structure, but it definitely means that we're having to try and rebuild this tissue in a three-dimensional way, and that's a real challenge.
Yes, you know, it's being a male, I obviously have never had the experience of pregnancy, but one of the things I always thought that the actual delivery, whether premature or not, had a lot to do with the muscular strength of the mother. But perhaps this plays a very minor role, being able to expel the...
that is really important. You're absolutely correct. The muscular strength, and that's why, you know, women that have significant scarring from a previous C-section, they're unable to then deliver that baby vaginally normally. And because of the scarring in the muscle, because the wave of muscle contraction moving through the uterus is starting at the top and moving in a wave through. And so if you have scarring there, the wave is stopped. It's like a barrier, and so you're not able to push the baby.
So
But
part
there's
of
so
this
many
thing,
other
I
things
see.
going
So,
on.
so you mean there are about 12,000 layers of research that is required to properly put all this
Absolutely.
together.
It's a hugely complicated process where many things are happening at once, and they need to synchronize so that you have, you know, a successful outcome at the end of the pregnancy. And so it's really, suddenly it seems to be not so surprising that if one of them, the timing is off, that the whole process can in some ways become dysregulated.
One of the big issues in science in America, especially about 15 years ago under the presidency of George Bush, was the use of fetal cells, stem cells. And the question is, the lack of having fetal stem cells at the time, was that a barrier to further research in this particular area?
Not in this particular area. We're very lucky in that, you know, we are working with fetal cells, in fact, because the fetal membranes, as I said, they're multi-layered, and some of the layers the baby makes, and some of the layers the mom makes, and they fuse together, and then they form this nice kind of layer of communication, again, between the mom and the baby. There's a lot of crosstalk that happens between the mom and the baby as the pregnancy progresses, through the fluid, but also through the tissues, through the blood exchange, through all kinds of these different types of mechanisms. And so what you see is the innermost layers of this tissue the baby actually makes, and the baby makes really early in the pregnancy, before it even decides, you know, which parts of the growing fetus are going to be nervous system, and which parts of it are going to be gut, and which part of, you know, so it's very early during the pregnancy. And so these cells in the fetal membranes have very interesting characteristics in that they can be defined as fetal stem cells, but the fetus, because the fetus makes them, but there's no damage to the fetus, there's no kind of the ethical issues that you would have collecting these cells at the end of pregnancy that you would have with other fetal cells.
And I have another question, which I find, is there any difference when you have a multiple birth pregnancy? Is there any difference in terms of the effects of early termination?
Absolutely, yeah. So the numbers of the percentages of pregnancy, if you have a twin or if you have a triplet, the numbers of those pregnancies that end preterm are much, much higher. So the more babies you have, the more chance you have of the pregnancy ending preterm. And this has been fascinating to people in the field for a very long time, because it's set up the idea of, do we have a maximum size that the mom can grow to and stretch to before, you know, you're expanded to your maximum limit? And I'm sure lots of ladies can agree with that. It feels like that. And so one of the ideas is that we don't know what that limit is, and that limit obviously changes from person to person a little bit. But definitely, if you have more than one baby in your pregnancy, then you're much higher risk of having an early pregnancy.
I see. Now, one of the things, whenever I talk to people who are involved in molecular biology and research at the protein level and enzymes and cellular level, is it seems like we've always had it around, at least for the last 20 years. It's just so normal. We kind of accept it as a natural state of being that you can do research at the cellular level or express a protein one way or another. The question is, was all this possible before the advent of computers?
Before the advent of computers, in the way that we have them now and the speed that we have them now, no. Because the amount of data that we're able to process, especially in light of looking at changes in large numbers of proteins and large numbers of gene expression. So what's happening, how are the cells reacting to different situations, different treatments, different medications, different times in the pregnancy. Now we can get huge amounts of information that we couldn't get before, and that is very much computer driven. So how do we manage, how do we crunch all of those numbers, how do we see how the puzzle fits together is very much driven by computers. Because some of those large, sort of looking at all the different proteins that you have or all the different genes that are working at one time in the body, it used to just absolutely overwhelm researchers. What do we do with, we don't know what to do with all this data. And it took time to build the tools, the computer-based tools, so that we can analyze this. We can see, okay, we have all of these from this pathway and all of these from this, and how do they fit together to be able to really understand the big picture of what that data was telling us.
So actually you can do simulations on
Absolutely.
the computer. You don't even need a test tube, any liquid. You don't need to get the floor dirty, so to speak.
People do that. People do that. They dedicate their life to running simulations and trying to understand, you know, if I change this one thing, what's the knock-on effect of the big picture?
Hold that thought. We're going to take a break. You're watching Boritzer's Bio Briefings right here on Think Tech Hawaii Television. And we'll be right back with our guest, Professor Clair Wright. Hi, my name is Dr. Rafi. Every week, I'm right here at Think Tech Hawaii, 3 p.m. on Mondays. My show is Boritzer's Bio Briefings. What do we do here? Well, we watch sperm swim. We see if they catch anybody. We check out the latest biosimilars. You know, the kind that, what was his name, the guy with the bicycle? I guess we forgot his name, but he was taking EPO and other human growth factors. We'll be talking about human growth factors. You want to know where to get some? Maybe I'll tell. Anyway, you can catch me, as I said, every week right here, Monday, 3 p.m., Think Tech Hawaii, Dr. Rafi. You can also find me on Twitter, BioInfo Medical. Or you can catch me on Facebook, Dr. Rafael Boritzer. I'll be happy to converse with you. Aloha. You're hot, we're not, and that's because you're watching Boritzer's Bio Briefings right here on Think Tech Hawaii Television. We're talking with Professor Clair Wright, expert or extraordinaire on preterm ending of pregnancies, and we're talking about where science has come a long way to everybody's thinking on trying to find the causes of early termination of pregnancies. And we were talking about how science, the use of computers and modeling, has actually changed a lot of the research. Because when I talk to some of my friends at JAPSOM, I said, so you have to be careful you don't get your hands dirty in the lab. And they said, no, I wash my hands in the morning. So I gather that this is not a big issue to worry about the beakers and the smoking chemicals and everything of that nature. A lot happens under the microscope, and a lot happens on the computer screen and the modeling as well. Signals that a pregnancy is not going well. What are the signals?
So usually the first thing that the mom knows about is so at the end, towards the end of the pregnancy, she has practice contractions. And so this is really one of the first things that the mom really notices is happening with her, and noticing that her body is changing and getting ready for the end of the pregnancy, so the delivery of the baby. So really how your body behaves in that nice quiet stage in the middle of your pregnancy is not what needs to happen at the end. And so in terms of danger signals, what might happen if the mom doesn't have an infection, or if the mom hasn't developed gestational diabetes or something like that, or if we've kind of got through those growth phases where, yes, the baby's growing properly and those kinds of things. then it's really is the mom's body ready too soon? In terms of, is the mom's body, the changes that have to happen, are they happening too early? And so you get some of those types of warning signals. Or you might even just get the case that the bag breaks early. So the bag just breaks one day and you don't really have much warning to that. The other thing that is interesting and that can cause preterm birth is the levels of fluid that are around the baby. So one of the things that physicians really monitor carefully is, towards the end of the pregnancy, what's happening with the fluid. Is there enough fluid for the baby? Is there not enough fluid for the baby? So that's also been an interest of my research group too.
One of the questions I'm curious about, we tend to put an emphasis, especially in the Western world, about what we can do to make things better in terms of our bodies, our lives, our thinking, our environment, and so on. We're almost driven to think that we are in total control of everything, which is very antithetical to the Eastern tradition of thought and philosophy. But in looking at some of this research that you're doing and your colleagues as well, is there such a thing as a perfectly desirable, perfect scenario for giving birth in terms of carrying the baby to term?
So you mean in terms of the timing, or
the timing, everything without a problem? Because from what I'm hearing, there's no such thing as a perfect birth without one issue or another, because, it's just...
I think it's much rarer than people think. And I think one of the things that's very interesting now is how many pregnancies go over term. And I think that's one of the things that's very understudied and would be a huge wealth of information for us to understand. So we try and study what happens if it happens too early, what's happening in the normal situation, if we can really define a perfect normal pregnancy, like you're saying. But we're not looking too much at those pregnancies that go over term. So the ones that have to be induced, because at that point then the changes that we're waiting for are not happening at all, and that would be a very interesting way to study normal pregnancy, but also those pregnancies that happen too early.
Because once we know what it is that makes for a perfect pregnancy, we can obviously set down the limits and standards and procedures and protocols that everybody has to follow. But very often, when you go to a physician's office, whether it's an obstetrician or an internist, he will give you the norms, whether it has to do with cholesterol level or whether with insulin levels or whatever. It's always, this is the norm. Well, this is not such a clearly defined perfect bell curve, and
exactly. And we see that that's why pregnancy, the end of pregnancy is timed within a 2-week window. And so, when we're counting and we're saying, okay, a normal gestation is 40 to 42 weeks, that's quite a large window, and it's only really a problem if it's before 37 weeks. So now we're talking about, okay, 38, 39, 40 weeks, 41 weeks. That's kind of a large amount of variation. And what you see is that there are changes between different populations slightly in length of pregnancy and what's normal, because what we want in the end is healthy baby outcomes. So what's the best length of pregnancy and the best healthiest delivery, so that we have the best pregnancy outcome, the best outcome for the baby, and the best health outcome for the mom, so she can recover.
Now, one of the new things that I've heard in the last few years is people planning the date of their birth so that they don't miss a particular event and they don't have to get a new dress to attend the sister-in-law's wedding or whatever.
Yeah, there was a global trend to people trying to decide when would be the ideal time for them to give birth, and that really is a mistake.
So that didn't take off in a big way.
That didn't take off in a big way, and what we saw globally is that a lot of physicians were much more comfortable, and definitely they're not now, and policy has changed, to let moms choose to have elective cesarean sections. So they would choose to have a cesarean section, because when you have a cesarean section, you know your baby is going to be born on a certain time and a certain day. But it's been really clear in research that delivering a baby normally is much more healthy for the mom in terms of recovery, because it's not a large surgery, but also is more healthy for the baby as well. And so the babies do better if you try to deliver normally.
I see. What about the drugs that induce birth? What about that?
So they work to varying degrees, and they take time to work. And so, yeah, that's one thing that is often also a surprise, in that if you're giving the hormone mimetic to induce the pregnancy, to induce the labor, it's not going to happen in 5 minutes. You know, and moms can
only on TV,
only on TV, and moms are still waiting hours and hours for the pregnancy to move on and to progress, and so, you know, it's not a perfect system now. In the same way as we don't really have a proper, really good test to say whether a mom is actually in true labor or not. The test that they use now is not very good at all. And so what they're doing is they're testing for a fetal protein from the fetal membranes. And if the protein is there, chances are that you're probably in labor. And that's about as good as it gets.
Let me ask you, there are a lot of women who are in the late term of their pregnancy often get all kinds of warnings from their gynecologists on what to do, what not to do, and so on. And don't exercise in this manner, don't do this, don't bicycle, don't run. What about traveling in airplanes?
Traveling in airplanes is interesting in that there hasn't, as you can imagine, there hasn't been that much research done on traveling in airplanes, because that means women have to sign up to actively travel in airplanes when they don't know whether it's safe or not. And so what's recommended by physicians now is that you can travel in airplanes and there's no real evidence that it's bad for you, but you know, not during the third trimester.
Yeah, actually, also, if you travel, you should travel in first class, because in tourist class it's 7,000 feet the pressurization or more. In first class it's much lower.
I think we'd all like to travel in first class.
Yes, but this is a good excuse if you're pregnant. You know, I must travel first class, maybe even in the pilot's cabin, or as long as the pilot is the husband, it's fine. Okay, I wanted also, before we end our show today, I wanted to talk to you about your previous work in dementia. This is one of the areas that interests me a great deal. And perhaps, what was I just saying? Oh, never mind.
Testing.
So tell me about your work, your early work.
Okay, so my earlier work for my PhD thesis, actually, when I was still in the UK, was working in the area of dementia. And it might seem that I've moved a long way from looking at brain cells to looking at fetal cells. But I think once you have a real strong interest in asking scientific questions, your interest kind of moves, and it's like a journey. And you find new questions and you find new things. But for that work, I was working on Alzheimer's disease specifically, and I was working in a large consortium, and what we were trying to do was to understand a little bit more about how the pathology for Alzheimer's disease develops. So what we usually see, kind of similarly to the end of pregnancy actually, is the end result of dementia. In that, we can't sample people's brains in the same way we can't sample people's fetal membranes. They need them while they have that function. And so what we would always see with dementia is end-stage disease usually. And so that made it very difficult to characterize. And so one of the things that's very devastating about dementia is that the amount of cell loss and the amount of damage that you have before you become symptomatic is huge. And so to really understand how the different features, so how the proteins that get misfolded and go wrong happen in the beginning of disease, was something that when I was doing my PhD was of great interest. And so what we were trying to do was to use examples of families that have very strong lineages of dementia, of Alzheimer's disease, and using that mutation that they have to study the processes, so to speed up the processes, and then looking at that developing in brains. So characterizing those features.
So actually, you can only figure out that someone had Alzheimer's after doing a post-mortem.
Pretty much, yeah. Yeah, and still, so diagnosis has moved on a little bit now since some of the MRI imaging techniques have got much, much better. There are some ways to see very early Alzheimer's disease using MRI imaging, so the magnetic resonance imaging that you can do, but you kind of need a heads up that you need to go and have a look in the first place. So that's the conundrum really. When do we have, with most people that maybe don't have a strong family history of dementia, which ones do we screen everybody? What do we do? And we look for those beginning changes to see that where we're losing the cells and essentially the brain is shrinking already, so that we can start to treat people earlier. So there were some very kind of challenging things with studying brain disease and aging.
Yes, I know that in terms of dementia, and especially of the Alzheimer's type, the medication and drugs used are really at their infancy. I mean, drugs like Aricept and all these other ones that perhaps give a very temporary, not so much regression, but stopping the process at a certain stage that it's already at.
Yeah, I mean, there's so much interaction between what's going on with the brain cells, but also what's going on with the immune cells in your brain. And that like you're saying, the drugs that really are designed at the moment for dementia work just on one of the brain chemicals. And it's really clear that many of the different brain chemicals are affected in dementia. And so you're just, you're just trying to attack the problem by just trying to hold back one of the things that really are a problem, rather than addressing like the whole combination to really try to slow down the disease, or even, obviously the ideal thing would be to reverse disease or to stop it completely.
Well, we're hoping to do in the future a roundtable discussion around the issue of Alzheimer's. It's really, especially with the longevity in the Western world, it's become an issue. Perhaps it's always been around, but we never were able to recognize it until we passed that magic mark of 70 as the age of end of life. So I hope you'll join us when we have that discussion.
Thank you.
We want to thank Professor Clair Wright, Chaminade University and University of Hawaii School of Medicine for coming with us today on our journey looking into the end of full-term pregnancies, or rather before full-term pregnancies, so to speak. And we hope that you'll join us again. You've been watching Boritzer's Bio Briefings right here on Think Tech Hawaii. Join us next week. And remember, we're watching you.